Um, Good afternoon, everybody. My name is Rita Gatonye. I am a harm reductionist from Kenya. And thank you so much for making time to come here today to step into a conversation that is as necessary as it is sensitive. I haven't seen this conversation discussed in the depth in which we're going to discuss it before at a harm reduction conference. Today we are talking about the intersections between drugs, sex, power and consent, and the role of communities. And we have a great set of panelists here who've done some amazing work. Our goal today is to get curious, to learn, to unlearn, and explore how substances interact with pleasure, boundaries, and power. And most importantly, how we can safeguard these experiences, reduce harm, respect autonomy, and create safer and healthier communities. So, welcome. Sorry. So, we are going to start on my extreme right. Second. We are going to start on my extreme right with Manoj Panthi Kanak. I hope I said that right. Yes. Kanak is a young queer health advocate from Nepal. After that, we are going to hear from Astro, Rafael, Feraci, Almeida. Astro is a harm reductionist and psychologist, and their project is focused in Brazil. See? And then we are going to have Dr. Claudia Stoicescu. And Dr. Claudia is a social epidemiologist researcher from Monash University in Jakarta. And then after that, we are going to have Worawalan. Okay, beautiful set of names today. Worawalan is a senior researcher at Mahidol University. Is that in Thailand? Okay, good. So far, so good. And lastly, we are going to hear from Professor Adam Bourne, Professor of Public Health and Director of the Australian Research Centre. So, Kanak, over to you. Kanak's presentation is focused on the situation of sexualized drug use and associated violence among men who have sex with men and transgender populations in Nepal. Kanak is a young queer health advocate whose work focuses on HIV prevention, harm reduction, mental health, sexual and reproductive health and rights, and human rights advocacy. Kanak has a bachelor's in public health degree, and they are currently affiliated to Blue Diamond Society, Nepal. Welcome.
Thank you so much. Namaste and a warm good afternoon to you all. I'm Kanak from Blue Diamond Society, Nepal, and today I'll be directing you all to share some of the key findings from a research that we did back in my home, Nepal, amongst gay, bisexual, and other men who have sex with men and transgender women. As you all are aware, sexualized drug use is something that is talked globally, and it has garnered a lot of attention through many years, decades of years, especially because of its strong association related to high-risk sexual behaviors among GB, MSM, and transgender women. So studies from around the world suggest that gay, bisexual, and other men who have sex with men and transgender women who engage in sexualized drug use tend to exhibit lower negotiation power. So their consent is breached and they are at high risk of being violated. So the aim of this research was to primarily understand the prevalence of sexualized drug use, and among the specific objectives were assessing the risk behaviors related to sexualized drug use, evaluate the types of drugs, the patterns of drug use, and finally, and pertinent to this particular slide, examine the prevalence of violence in the settings of sexualized drug use. Talking about the methodology, so we did a nationwide cross-sectional mixed method study using standard tools that have been previously used in other different parts of the world. So we employed a two-stage cluster random sampling technique and the sample size was 400 individuals. So we did this research in 14 out of 77 districts of Nepal, spanning all 7 provinces. And the data was collected between June 30 to October 30, 2024. In terms of the qualitative survey, we did KIIs and FCDs. So let's look at the results, which is the prevalence of sexualized drug use. So as you can see, among the 393 study participants, 142, that is 36.12% of the study participant reported engaging in sexualized drug use, while the prevalence of chemsex was 7.21%. So you should be mindful that this prevalence is ever engagement in the lifetime. So when I say 7.21% of people reported chemsex use, they're saying that they used crystal meth, GHB, ketamine ever in their lifetime. So poly drug use was very much prevalent, with individuals reporting up to use of 6 different types of drugs, sometimes alone and sometimes in combinations as cocktails. So another thing that we should be really mindful about is that the prevalence of sexualized drug is quite large in comparison to chemsex, because Nepal is a region where the chemsex drugs are not readily available. So you can see that the most used drug was cannabinoids. So Gaza, as we say in our language, Gaza and its derivatives were the most used drug, while use of cocaine, heroin, and amphetamine derivatives was also concerning, reported by 21, 20, and 13 individuals respectively. So another important thing that we should be noting here is that among those reporting sexualized drug use, the vast majority, that is 91.55%, were young people, and they used a sexualized drug before or at the age of 21, 25, and MSM were the largest subgroup of sexualized drug users. Now moving on to violence in the settings of sexualized drug use. So unconsensual sexual activities was alarming. It was reported by 40.14% individuals who said that their partners during sexualized drug use expected not to use condom. So this was a huge issue. Similarly, being drugged by their partners while under the influence was also a big issue, which is reported by 36.62%. So here's another anecdote from the qualitative data where one participant shares, when sober, I am aware I should use a condom, but after using drugs, I was not even sure whether I was using a condom or not. So it is not just about being forced not to use a condom, but lack of awareness when under the influence of drugs. Similarly, when we try to understand why is the situation that individuals are being asked not to use a condom? So like I am a queer person, I'm from MSM TG community, so when I'm having sex with someone and I talk about like when did you last get tested, so they feel very violated, they feel very like questioning like their HIV status, like I'm physically fit, why are you even asking the question? So that is a level of stigma and, around HIV. So you can see in the findings there, he was reluctant to use a condom, citing his muscular, seemingly HIV-free, healthy body. So while this is the general scenario, the scenario is even murkier and even difficult when under the situation of, when under the influence of drugs. So another experience shared by one of our key informants was that I went to a party where there were all kinds of drugs, and it was like a scene from a movie. No one was using a condom. I could not take the risk and left. So party drug scene is slowly and gradually increasing in Nepal, especially in the hubs like Kathmandu. Now, we've already talked about unconsensual drug use forced by their partners, and also about condom use. So now moving on to violence in the settings of STU. 45.07% of the study participants reported ever experiencing violence. So the most frequent was verbal violence, followed by physical and sexual. So facing violence was not only the issue, perpetrating violence was also an issue, which was identified among 26.76% of the study participants who said that they perpetrated violence against their sexual partners while under the influence of drugs. So when you try to understand why is this happening through our qualitative research, one of the study participants shared, violence can occur during sexualized drug use when one partner wants to have sex for a prolonged period, but the other has lost sexual desire. So among the two partners, if one is not using drugs and the other is using, then there is definitely a friction. There's definitely going to be violence. So what are the conclusions from this research? Chemsex and sexualized drug use is definitely a public health issue among MSM and TZ community in Nepal. This is the first of its kind research, and we did not expect to find such a large prevalence of chemsex use, sexualized drug use, and also violence. So there is a need for a comprehensive harm reduction program on sexualized drug use. So based on the findings of this research, there are a few recommendations that I want to talk about. So the first is development of targeted educational materials. So the educational materials that we have in place right now for the MSM-TZ community is only about you should get tested often, you should take the ARV regularly, take PrEP, but there's nothing about chemsex. So we need to make more IC and BCC materials related to chemsex. Next is offering mental health support. So mental health support, not just as a reaction to violence, but also to help people understand why are they being engaged in chemsex or sexualized drug use, what are their motives, how can they reduce harm. Then training healthcare providers. As I said, there's no any awareness regarding sexualized drug use or chemsex among healthcare providers. So training and orientation to healthcare providers is a must. Stigma and discrimination reduction. There's already a lot of stigma and discrimination related to homosexuality or transgender identities. And if we add drugs to this equation, there's going to be a multiplied level of stigma and discrimination. Finally, empowerment of community organizations. Blue Diamond Society has 25 different network organizations that provide HIV services, and they are grassroots level organizations who lack understanding about chemsex. So empowering them, providing them with the resources, the knowledge is very much important. Finally, and most importantly, advocating for supportive policies and funding avenues, because the existing harm reduction concept in Nepal is only needle syringe exchange programs or rehabilitation care. So there's no understanding about chemsex and sexualized drug use. So we need to integrate that and funding avenues, because the PEFAR USAID funding cuts has severely affected MSM and TZ community in Nepal. Our 25 intervention sites have been closed down. So finding alternative source of fundings is very much important. So yeah. That is pretty much everything about my slide. Thank you so much. What I shared was a small portion of the research that we carried out. So I've also brought report which has key findings from the research, so you can take this from the desk. Yeah, thank you so much.
Thank you. Thank you so much. Thank you so much, Kanak, and thank you for the very elaborate presentation on what is novel and very important work in Nepal. And it's interesting that you say that, because our very next speaker knows quite a bit about some of the things you've touched on, which is polydrug use, the party scene, and chemsex. And we are looking forward to them telling us what partnership looks like in this context, what harm reduction looks like in this context. So Astro, Rafael Feraci de Almeida, is a transmasculine harm reductionist and psychologist with experience in street and party outreach action through the Edelay Drop-In Center and the Respire Project, thinking about subjective and singular care, and is a speaker and creator of digital content on harm reduction and mental health. Their presentation is called Harm Reduction and Ballroom, Life Technology Beyond Health. Bienvenido.
Boa tarde. Boa tarde. Queria agradecer, primeiramente, de estar compondo esse espaço e de estar podendo falar a minha língua, porque eu não sei muito bem falar qualquer outra que não seja essa. Então, agradecer diretamente também, Silvi, por estar se disponibilizando a fazer a tradução aqui para vocês.
Buenas tardes. Me siento muy feliz de estar en este espacio. Agradezco que estén en este espacio conmigo y sobre todo que pueda hablar en mi propia lengua porque no me siento muy cómodo hablando en otra lengua. Entonces quería también agradecer a Silvi por disponibilizar su tiempo para esto. And I was also thinking that as it's going to be in Spanish on the screen, I'm going to translate to English so it makes it better for all of you. And who doesn't speak English can read the Spanish on the screen, and I think it's a very democratic way to go.
Então, quem sou? Eu sou Astro, sou representante aqui pelo projeto Respire, do Centro de Convivência Edley, psicólogo clínico e criador de conteúdo nas redes de Instagram, @astrolandia.rd.
And so I'm Astro. I am a harm reductionist from São Paulo, and I'm also a content creator from Instagram called astrolandia.rd, and I am a clinical psychologist.
E o que eu gostaria de estar propondo hoje é a reflexão dentro do assunto da redução de danos e os bailes Ballroom, a saúde mental para corpos dissidentes, especialmente para pessoas trans, negras, periféricas e LGBTQIA+. Não podemos pensar nessa categoria apenas sobre a ótica biomédica ou individualizante. Na prática, esses corpos já estão construindo cuidado de dentro para fora, onde não é visto.
I would like especially to talk about trans, Black, peripheral, and LGBTQIAPN+ people, because we cannot think about this category solely from a biomedical or individualizing perspective. In practice, these bodies already create care that is collective, community-based, and insurgent.
A cena Ballroom surge num território de afeto e reparação simbólica frente à exclusão estrutural. Ela cria uma rede onde o pertencimento é um fator crucial para o fortalecimento psíquico. Quando uma pessoa entra numa house, por exemplo, ela encontra uma família escolhida que fornece suporte emocional, material e de acolhimento. Esse senso de comunidade combate diretamente efeitos do isolamento, da transfobia, da LGBTfobia e do racismo e da marginalização econômica, que são fatores que atravessam a saúde mental.
The ballroom scene emerges as a territory of affection and symbolic healing in response to structural exclusion. It builds a network where the sense of belonging is crucial from strengthening mental resilience. When someone joins a house, for example, they find a chosen family that offers emotional, material, and welcoming support. This sense of community directly combats the effects of isolation, transphobia, LGBTQ phobia, racism, and economic marginalization, all factors that deeply affect mental health.
Assim, a cena Ballroom atua com um espaço terapêutico informal, um campo onde a gente vive o cuidado de forma encarnada, no toque, na dança, no olhar e nas palavras trocadas entre a cena.
Thus, ballroom acts as an informal therapeutic space, a field where care is experienced in an embodied way through touch, dance, gazes, and the words shared in this scene.
Linkando a redução de danos, pensando na política de vida nos espaços dissidentes, as estratégias de redução de danos aqui se restringe ao campo das drogas, mas vai para além deles, dialogando com eles, principalmente. Mas se expande para as práticas cotidianas de autocuidado e estratégia de sobrevivências.
Linking harm reduction to the politics of life in dissident spaces, harm reduction strategies here are not limited to drug use, although they do engage with it, but they expand into daily practices of self-care and survival strategies.
Na Ballroom, o conceito de espaço seguro não é um slogan, é uma prática. A partilha de informações sobre saúde sexual, não à toa, essa cena surge a partir de travesti preta, HIV mais positiva. Assim, o uso seguro também de substância é conversado, e é isso que nós, dos projetos Respire, fazemos, encontros para a gente compartilhar e falar sobre essa prática. Apoio mútuo em crise emocional e construção de espaços onde corpos racializados e dissidentes possam se expressar sem um olhar normativo e violento do mundo externo.
In Ballroom, the concept of safe space is not a slogan, it's a practice. Information about sexual health, safe substance use, mutual support during emotional crisis, and the construction of spaces where racialized and dissident bodies can express themselves free from the normative and violent gaze of the outside world are all shared.
Com a redução de danos, como ética para o olhar e cuidado, as práticas dão pelo cuidado das pessoas que fazem parte do baile Vogue. Promoção de diálogo sobre cuidado comunitário e políticas de proteção de dentro para fora da cena. Logo, a dança faz a costura da construção de laços e cuidado.
With harm reduction as an ethic of care, practices unfold through caring for the people participating in voguing, promoting dialogues about community care, and building protection policies, both within and beyond the scene. In this way, dance weaves the creation of bonds and care.
Com a arte Ballroom, a estética como antídoto e afirmação de vida envolve um movimento artístico, é superversivo, politizando o corpo em performance e faz da estética uma prática de afirmação de vida.
Through ballroom art, aesthetics become an antidote and an affirmation of life. The artistic movement is subversive, politicizing the body in performance and making aesthetics a practice of vital affirmation.
O corpo que dança Vogue, que desfila no Realness, ou que se apresenta no Face, está ressignificando os olhares sociais sobre si. A arte na Ballroom é cura e cartaz. É no gesto coreografado, no look montado na passarela, que se exorcita a dor e se encena a potência da existência dissidente.
The body that vogues, that walks in the realness, that presents in face, is a re-signifying society's view of itself. Art in ballroom is both healing and catharsis. It is through choreographed gestures, through the looks crafted for the runway, that pain is exercised and the power of dissident existence is represented.
A Ballroom cria mundos onde as subjetividades são reconstruídas e celebradas. É onde o que a sociedade tenta apagar ganha luz e protagonismo. Isso tem efeitos diretos na saúde mental e no imaginário coletivo de quem faz parte da cena.
Ballroom creates worlds where subjectivities are reconstructed and celebrated. It is where that which society attempts to erase is brought into light and given center to stage. This has direct effects on the mental health and collective imagination of those who are part of this scene.
Logo, a intersecção racial entre as três esferas se dá quando juntamos saúde mental, redução de danos e arte Ballroom. Estou aqui falando de práticas e tecnologias sociais que são construídas de dentro para fora pelos próprios corpos dissidentes e marginalizados.
The radical intersection of these three spheres, mental health, harm reduction, and ballroom art, happens when we combine these elements. We speak of social practices and technologies built from within by dissident bodies themselves.
Não se trata apenas de oferecer o cuidado, mas de reinventar o que é cuidado, o que é sobrevivência e o que é arte em um mundo que insiste em marginalizar essas vivências.
It is not just about offering care, but about reinventing what care is, what survival is, and what art is in a world that insists on marginalizing these experiences.
Os encontros no baile, então, vira uma estratégia de saúde coletiva, uma política de redução de danos emocional, estética e social e uma resposta direta ao racismo estrutural, LGBTfobia e a cis-heteronormatividade.
Dance gatherings then become a collective health strategy, a policy of emotional, aesthetic, and social harm reduction, and a direct response to structural racism, LGBTQ phobia, and cis heteronormativity.
Logo, a Ballroom é a prática de toda a teoria que estamos falando sobre redução de danos, assim, tecnologias de vida.
Ballroom is then the living practice of all harm reduction theory that we're sharing here. It is therefore a technology of life.
Gracias.
Wow. Wow, wow, wow. Thank you so much, Astro. I wish I had read that in English in the first place. I wish I knew just how amazing that work was. That's what language barrier does. That's some really, really powerful words about the use of art for life and about giving the power back to communities within their own safe spaces. Just brilliant, brilliant. Thank you, Astro. Our next speaker also has done a lot of work in terms of returning power to communities in their own spaces. Dr. Claudia Stoicescu is a social epidemiologist and policy analyst with expertise in HIV, gender-based violence, substance use, and drug policy. She is passionate about participatory community-based research and addressing the inequities faced by underserved groups affected by HIV and substance use. And today, she will be talking to us about transgender women initiating new goals for safety, co-adapting an evidence-based intervention to reduce gender-based violence, improve health and well-being, and increase access to justice in Indonesia. Welcome, Dr. Claudia.
Thank you very much for that introduction. Good afternoon, everyone. I am Claudia Stoicescu. I am a researcher based at Monash University Jakarta campus. For those of you who didn't know, that we do have a Jakarta campus. And I've been working in Indonesia for almost 15 years now. I'm very excited today to present on TWINGS, which is short for Transgender Women Initiating New Goals of Safety, a new project aimed at addressing gender-based violence, HIV risks, and improving access to justice, social support, and healthcare, including harm reduction for transgender women in Indonesia. The work that I'm presenting today is part of an ongoing randomized controlled trial that we're running in the country to test the feasibility and efficacy of this program among more than 250 trans women across 2 Indonesian provinces. And today I'll focus specifically on the pre-trial adaptation formative work and process that we use to guide building the TWINGS program and ensuring that it really meets community needs. And what I mean by adaptation in this context is modifying an existing evidence-based program or intervention while preserving its core elements or logic. Better? So why are we focusing on trans women? Why now and why Indonesia? Globally, trans women face much higher rates of gender-based violence than cisgender women, and they're almost 3 times as likely to experience sexual violence. In our program, gender-based violence comprises physical, sexual, economic, emotional, and psychological abuse by both intimate and non-intimate partners. But it also includes discrimination and persecution that violates human rights, such as being denied healthcare, social welfare, legal aid, and other services, or being arbitrarily stopped, detained, or incarcerated. This overlapping exposure to multiple types of violence and discrimination has been shown in multiple geographical locations to lead to poor HIV outcomes, severe mental health challenges, increased social marginalization. Indonesia is the 4th most populous country in the world, with more than 275 million people, and the largest Muslim majority nation. And while Indonesia has a long history of gender diversity, transgender people today face multiple layers of structural discrimination, stigma, and barriers to healthcare. Trans women make up over 70% of documented cases of violence against LGBTQ community in Indonesia, and 12% live with HIV. There's currently no coordinated gender-based violence response for trans women in the country, and they are routinely excluded from existing violence, health, and harm reduction services. Recent laws in Indonesia, including a 2022 revision of the criminal code, further marginalize LGBTQ groups by criminalizing what is framed in the criminal code as deviant identities and behaviors. And since those laws were enacted or passed, several local and state policies have now already criminalized what is labeled as deviant identities and behaviors, which include gender nonconformity. Now, in recent years, such policies have justified increased raids and arrests by law enforcement on the trans community, as well as forced rehabilitation of trans people, which is intended to restore their social function, in the words of the authorities. And that brings me to the program that we're adapting and testing at the moment. So T-WINGS is adapted from WINGS, or Women Initiating New Goals of Safety, which is a screening, brief intervention, and referral to treatment model that addresses gender-based violence and its links to drug use and HIV. This was originally developed for women who use drugs in the criminal justice system in the US by colleagues at Columbia University Social Intervention Group, and has since been tested and adapted and implemented in 6 countries and translated in 8 languages. The program can be delivered in multiple ways. It can be delivered as a self-paced, computerized model, as a digitally assisted model, or as a more traditional model delivered by a case manager, outreach worker, or peer advocate. It comprises 8 core elements centered on psychoeducation, screening, motivational interviewing, safety planning, and social support network enhancement, followed by identification and prioritization of service needs, and then linkage to services. Now, our adaptation process, which is intended to make this program feasible, acceptable, and relevant to the needs of trans women in Indonesia, combined 3 aspects, which I'll talk about in a little bit more detail. One is a deconstruction, reconstruction framework, participatory design, and formative research. And I'll go through each now. So we started by conducting qualitative interviews with a number of trans women across Indonesia, and healthcare providers, social service providers, and law enforcement to understand community needs, priority issues, and considerations for implementing the program. There are a lot of findings. I'll focus on 3 main ones today. One key finding was that structural violence and discrimination were a major, almost daily event in the lives of trans women, which made issues such as access to justice and legal aid non-negotiable elements of the program we were building. The original program was very much focused on intimate partner violence and violence from intimate partners, and this was a very different context we were dealing with. Participants described experiencing discriminatory policies and practices by service providers and the police, which included frequent police raids on their homes and sex work locations, and frequent physical and sexual abuse by the police during the detention and arrest process. They also reported barriers in obtaining state-issued ID cards, which is a key issue because the government does not recognize identities outside of the gender binary. And without a government-issued ID, it's very difficult to access education, healthcare, social services, and formal employment, and also further exposes trans women to harassment and discrimination. And the third key finding that I'd like to emphasize here is that there is very limited to no access to gender-affirming care and information, which pushes many trans women to seek non-medical hormone treatments and illicit silicone injections, which increases their risk of serious health complications. And we documented in our study several instances where there were also deaths resulting from illicit silicone and hormone use due to the lack of gender-affirming care. Another key issue that we found was around the central role of sex work in the lives of trans women and the related harms from related violence from clients and the police. This then in turn emphasized the need to integrate into the program harm reduction strategies that combine violence prevention, condom negotiation, and education around sex work harm reduction and Chemsex to reduce HIV and sexual transmitted infection risk. We also found significant intersections with mental health, which was linked to the cumulative impact of many of the issues I mentioned earlier. Despite these challenges, we also identified through formative research that the trans community has developed powerful strategies for resilience, including creating interpersonal support networks, establishing communal safe spaces, building organizational support structures led by and for trans women. This included providing informal gender-affirming information and care through a harm reduction lens, which is a significant gap in formal service provision. So in response to what we learned, we adapted the original program by developing and adding a dedicated module on human rights and access to justice, working with community paralegals who are also trans women, as well as co-designed with a legal aid organization. This ensured that access to legal support, knowledge of rights, and community empowerment became central pillars of the adapted program. And we did the same with sex work harm reduction. So we worked with the community to find what was already being implemented in the community in terms of harm reduction strategies and integrated that into a module, an additional module to the program. And finally, we collaborated with a collective of doctors called Doctors Without Stigma to make available a directory of trans and LGBT-friendly medical and mental health services across Indonesia, which we then integrated into the program. Another key part of the adaptation process was building long-term engagement with the trans community and really centering trans-led organizations in this work. From the start, we committed to sharing power and decision-making structures. We partnered with trans-led organizations to develop grant proposals for this program, to identify community needs, to co-create the research questions, and to make joint budget decisions. And building the real trust took time. And we had to confront a deep history of exploitation and harm that trans communities in Indonesia, as well as in many other countries, have faced in health research and in partnerships with health researchers such as myself. So throughout the process, in addition to the broader relationship that we've built for years with the community, we also established a community advisory and accountability board made up of trans community leaders, which guided all aspects of our adaptation and implementation. So one example, in the context of frequent police raids, we worked together with the community representatives on the board to determine that program delivery would best be offered through trans-led, trans-operated spaces, like usually organizations that operate as an activist civil society organization, but on the outside they are a beauty salon to protect them from community intervention. And we put protocols in place, including, for instance, having community paralegals present whenever there were more than a few trans women gathering in a particular space that would attract too much attention. We also worked with a trans filmmakers collective to produce audiovisual material for the program to make it accessible to community members with low literacy, because one of the other findings was that there was quite low literacy in some of the provinces we worked in among the trans community. And then finally, we applied an evidence-informed deconstruction construction matrix to bring together all of these community insights, formative research findings, and issues around ethics and safety. This adaptation method was initially developed by colleagues at Columbia, Professor Alvin Wu, and used initially to adapt HIV behavioral interventions for men who have sex with men in the US. And the process began by deconstructing the original program, so mapping out what each of the core activities and the targeted mediators and outcomes, and then reconstructing it to fit our new findings, to fit the new target, context, and modality while preserving its initial theoretical integrity. So one example I mentioned earlier here is that the original intervention was very much focused on intimate partner violence. It became very clear that this focus was insufficient for the trans community, and so we developed additional modules on human rights, discrimination, persecution, sex work, as well as HIV and STI reduction. And I want to just share some images from our community pilots and also the very exciting video and photo shoots that we had to build program for the intervention. So in summary, and our peer researchers now being trained to deliver the randomized control trial and to then be able after the trial to deliver this program within their own organizations, which is the next step. So in summary, we tailored the program. The tailored T-Wings program contained a lot of audiovisual content, which was not present to the same extent in the original program. We also used local dialects, not just Bahasa Indonesia, the formal Bahasa Indonesia, the national language, but we learned by working with the trans community that the trans community had their own language and their own terminology and their own way of communicating, and we integrated that into the intervention. And this was also different across different provinces. So it was a very complex process. It also included the trans-friendly service directory and community-designed new modules. And recognizing the crucial role of peers in supporting participants in the program to then lead them through service referral and support them to access the services that they have prioritized and identified was important. So we have been working with them, providing them with strong guidance, training, and ongoing support throughout the project through our organizational partners. And their leadership has really been key to building trust with the community and making this program successful. And these are some examples. I didn't think that playing the videos and some of the audio visual content for you would make sense because it's in Bahasa Indonesia, but just to show you a little bit of what it looks like. So it's on a tablet. And there are various modules that go through the 8 elements, including vignettes with examples of some of the issues that trans women face around violence and persecution that were taken from the qualitative research. And modules that are all accompanied by audiovisual content, videos, audio, and so on, to engage participants and ensure that there are multiple modes of experiencing the program and engaging with it. So in closing, I think I'm running out of time. We're excited to finally be implementing and hopefully next year, and depending on funding, scaling up this program. So hopefully at the next conference, I can actually present the results of the randomized control trial. Very excited that this is, I think, to our knowledge, the first gender-based violence and access to justice program that's been adapted and tested specifically for trans women in the region. Since last year, we've trained 3 trans-led organizations and 11 peers to implement the program, and we're hoping to expand that number. This is in September. And we've also developed an implementation manual, which can be used by other organizations post-trial. And we're currently conducting a process evaluation to assess how closely the program is delivered to our design and how satisfied trans women are with it. And so far, the information is looking good. I haven't fully analyzed all of the data. I suppose if there's one key message I want to leave you with is that trust and equitable partnership with affected communities and with people with lived experience is really a non-negotiable when we do research and implementation work. It shouldn't be an option, but it really must be now essential to the way we approach both research and implementation in this space. Thank you very much for listening, and thank you to all our participants and funders.
Thank you so much, Claudia. And I think I speak for everyone when I say we look forward to seeing the results of this pilot project. God knows we need it in the rest of in other parts of the world. And thank you for being honest about having to confront, the ethical considerations that have not been looked, the exploitation that's been there before, not just in research, but in practice. So our next speaker is going to talk about power dynamics, among other very important things. Worawalan, I can't say the second name, I'm sorry, practice over coca tea. A senior researcher at Mahidol University, focuses on gender, sexuality, HIV/AIDS, and sexual health. Her work includes MSM Chemsex research, COVID-19 impact on LGBT youth, interventions for migrant workers, M-Health for HIV self-testing, and cyberbullying prevention in Thai youth. Her presentation is on power dynamics, Hualok, and loss of control in high-fun or chemsex settings, a qualitative study among gay, bisexual, and other men who have sex with men in Thailand. Welcome, Worawalan. Radhika.
สวัสดีค่ะ Good afternoon, everyone. Thank you for staying with us in this late afternoon. Today, I'm pleased to share with you my study on power dynamics within high-fun spaces. To begin with, high-funs often called chemsex among gay, bisexual, and other men who have sex with men in Thailand often involves the use of kissomets during sexual activities. These high-fun activities happened between sexual partners or within a group sex setting and are often extended over long weekends. Participants intentionally use drugs to enhance sexual pleasure within the high-fun context. We observe dynamics power relations. Power shift depending on factors such as sexual preference, confidence, and social class. These personal attributes and actions, including who leads, who follows, and who gets included in these spaces. Through this study, we aim to better understand these unique power dynamics and how social norms shape and shift power within high-fun setting in Thailand. In this study, we recruited GBMSM participants through local NGO in Bangkok, Khon Kaen, and Pattaya. We recruited 30 participants who had engaging in sexualized drug use activity within the past 12 months. Data collection included 5 focus group discussions and 6 in-depth interviews. We then analyzed data using thematic analysis to identify key patterns. Now, Let's look at who participated in that study. Among 30 GBMSM participants, most were between the age of 26 and 35. 10 participants were living with HIV and 9 were currently on PrEP. 7 participants were non-tied. Most participants, 23 out of 30, reported using crystal meth before ordering sex. Some also mentioned using other substances such as ecstasy or MDMA, ketamine, cocaine, and GHB or GBL. In this study, participants said that high fun spaces were places where they could explore their sexual identities in a free and fluid way. They shared that high fun gave them a break from the rules and expectations of societies. It was a space where they could be anyone they wanted to be, without feeling judged or labeled. Many participants said that their sexualities felt more open and fluid during high fun activities. They could try new things, be themselves, and not worry about fitting into traditional ideal of gender or sexuality. In high fun setting, there was no need to act a certain way or hide who they are. It was a space for real and honest connections with other men. However, while high fun spaces allowed for sexual freedom and fluid identities, there were also forms of power and control within these spaces. Participants described how power was shaped by different types of capital, including financial, social, and sexual capital. One person could have many types of capital at the same time. For example, in high fun setting, GBMSM who were seen as more attractive, had fit bodies, or were top, often has more power. They could influence things like choosing partners, deciding on sexual practices, and controlling access to drugs. Besides physical, social, and economic capitals, race could also become a source of power in high fun spaces. However, money was not always the only form of power. Power could come from many different things. Sometimes people with more power would take advantage of others with less power. This could include controlling who gets the drug, using pressure or force, or leaving others out of the group in high fun activities. Here are some quotations from our focus group discussions. These examples show how participants describe sources of power within high fun setting. They highlight how factors such as look, body type, race, and social class could influence who had more power during high fun activities. For the first quotations, if you are the host, people automatically respect you. Even in a group setting, the host is still in control. Host here refer to men who are hosting the high fun party, and yes, they have a lot of power. In addition to sources of power, our study also found that loss of power and control was a major issue within high fun settings. Participants who had less capital, such as less money, weaker networks, or less desirable appearance, often had less power. This meant they had limited access to drugs, fewer choices in partners, and less control over the shared space. Some were even forced into sexual roles they didn't want or experience pressure, threat, or violence. Another importance is the concept of Hualok, losing self-control. Participants who lost control of themselves either by overusing substances or behaving beyond group norms often lose their social power. They could be excluded from the group just negatively and not invited to the future high-fun activities. Overall, our findings show that maintaining control over emotions, behavior, and drug use is an important norm within high-fun spaces. Those who can manage themselves by conforming to group norms can maintain their power within the group. Here are some quotations from our focus group showing how participants describe Hualok, losing self-control, and with a behavior that could lead to loss of power and being excluded from the group. For the second quotations, no one wants to play with someone who looks lost, alphabet, or creepy, Hualok. This quote highlights how important self-control was for maintaining one's space and power within high-fun group setting. In conclusion, having less power in high-fun setting or losing control through Hualok behavior may increase risk. These risks include physical and sexual violence, non-consensual sex, overdose, and dangerous drug mixing. There are also social and mental health risks, such as being excluded from the group, being taken advantage of, and experiences shame or anxiety afterward. However, freedom and being fully oneself, is it very true in high-fun space? High-fun spaces may offer freedom from social control and expectations, but men in high-fun setting often value self-control, and therefore men who lack self-control, Hualok, are looked down. So, do high-fun spaces reproduce social hierarchy and internal control through the concept of Hualok? I would love to hear your thoughts during the next discussions. Okay. To address this issue, intervention should empower GBMSM with less capital. This includes addressing unequal power dynamics, promoting agencies and informed decision-making, and supporting effective communications. It is important to support open conversation about drug limits and facilitate peer-based dialogue. The concept of Hualok offers a useful lens to understand power dynamics that may be reproduced from Thai society. More research is needed to understand this concept, and if Hualok translates to other Southeast Asian countries. The last slide. I would like to sincerely thank all the participants who shared their experiences and made this study possible. I also wish to thank the Community Advisory Group for their guidance and feedback throughout the study. Finally, I would like to express my deep appreciation to our community partners, IHRI, HORN, and ACT team for their support in recruiting participants and making this research possible. And of course, welcome Trust for funding this study. สวัสดีค่ะ ขอบคุณค่ะ Thank you.
Thank you. That was very, very interesting. Very interesting. Very interesting. I don't even have anything to say, but I know Adam has worked with you a lot on the issue of power dynamics. So we'll go right to you, Adam. Adam Bourne is a professor of public health and director of the Australian Research Centre in Sex, Health and Society at La Trobe University in Melbourne. He leads a large program of research in LGBTQ plus health and well-being, including multiple AOD-related projects, that's alcohol and other drugs. The presentation is on impactful drug use and harm reduction in LGBTQ plus communities, perceptions, norms, and community health practices. Welcome.
Thank you very much, Rita. Buenas tardes, everyone, or maybe even buenas noches at this point in the evening. That was a great talk and a really tough act to follow, but I'll do my best to keep you engaged as the very last speaker of the day. I wanted to start by acknowledging the wonderful team of people who work with me at the center, particularly Jean Lim, who manages this project, Ruby, Gran, Adrian, and Ruth. This is a project that's done very much in partnership with an LGBTQ community organization in the state of Victoria, where I'm based, called Thorn Harbour Health, with funding from the Victorian Department of Health. So, I guess I want, as a starting point, to remind everyone of the prevalence of alcohol and other drug use in LGBTQ communities. The basic point to understand on this slide is that it's much higher than what we observe in many, many other populations. In Australia, we're very fortunate to have a periodic household survey that captures trends in drug use over time. For the last 15 years, they've been able to capture and disaggregate data relating to sexuality, so we can compare lesbian, gay, and bisexual experiences with those of heterosexual people. The basic message is that in relation to every type of drug, legal and illegal, you see that prevalence of use is much higher among lesbian, gay, and bisexual people. And while this particular data set doesn't speak directly to those who are trans or gender diverse, the best available data tells a very similar story. Further to this, though, we know that LGBTQ people are more likely to engage in polydrug use, using more than one drug at a time. And that's use of certain drugs, particularly drugs like crystal meth, as you've heard already, is many, many times higher, sometimes up to 5 or 6 times higher than we see in other populations, but also drugs like GHB as well. There's also some contexts of use that look and feel different for LGBTQ plus people, and some that are unique. While anyone can use drugs during sex, this is much more common among LGBT people than is the case for cisgender and heterosexual people. The reasons for this higher prevalence of use are multifaceted, and I'm always really skeptical of singular explanations. The two that I think are most commonly talked about, the minority stress theory, which suggests that LGBTQ people's experience of stigma, discrimination, violence, and abuse shapes poor mental health outcomes, which then prompts drug use to manage or mitigate the effects of that poor mental health. I think a much more strengths-based way of framing this acknowledges the role of drugs in queer community connection, in pleasure, and also in identity affirmation. In addition to the higher prevalence of drugs, we also see different social norms relating to drug use in LGBTQ communities. There's evidence from multiple countries that as a population, we hold more accepting attitudes towards drugs, and we can live in quite dense social networks of people who use drugs. But like any population, we do still experience harm. A large survey we ran a few years ago of LGBTQ plus adults in Australia found that 1 in 7 participants, that's about 15%, who had used drugs said that they struggled to manage their use or that it negatively impacted their everyday life in the last 12 months. Of those, only a small proportion, about 22%, had accessed any kind of professional support, even though they said it was having a negative impact on them. And other research tells us that when LGBTQ people do engage with professional services, they often tend to be in more acute circumstances than we might see in other populations. So then the question we've been interested in, if it's a context where drug use in general is much higher, where there are different forms and different sites of drug use, where there are different norms relating to drug use. How does this shape when or how people come to think of themselves as having a problem that might require attention to ensure that harms are minimized? So within a queer community, what constitutes problematic or impactful relationship with drugs? How is the notion of problematic use or harm in general shaped by queer-specific social norms and cultural contexts within LGBTQ communities? What are some of the pivot points or critical incidents that motivate engagement with either professional or peer-based support? I guess the one thing I really want to emphasize is that I've spent most of my career trying to depathologize drug use in queer communities and to counter any assumption that drug use is inherently problematic, because I really don't believe that. So please understand here, our intention is not to suggest that there is a problem, but rather to try to understand how people come to think about whether there is a problem in these unique social and cultural circumstances, and then to explore how we can draw on the strengths within queer communities to enable harm reduction, rather than considering the role of community only in a deficit-based way as the source or the context of harm, which sometimes I think has been the case. So we interviewed 40 LGBTQ plus people in our state of Victoria, with lots of diversity in gender and sexuality, who self-identified that they had experienced problems in relation to their drug use, in whatever that meant for them. We weren't applying an objective criteria. We also interviewed 21 alcohol and drug use service providers and spoke to them about the presenting issues, the client-expressed motivations for help seeking, understandings of problematic or impactful alcohol and other drug use, and some of the harm reduction responses. As a starting point, I think it's important to understand how impactful or problematic use could coexist with non-impactful use, and that not all impactful use requires professional support, of course. Recognition of impactful use that prompted help-seeking behaviors typically involved a more gradual, incremental awareness of negative effects of their substance use, rather than a sudden realization or epiphany. These experiences could be broadly categorized into several distinct themes, and some I think would be commonplace across any population. So I'm going to mainly focus on the dimensions that specifically engage with notions of gender or sexuality. So first up was cultural narratives of such substance use. So these narratives actually speak to a general perception among some participants that rates of impactful substance use were inherently elevated within the LGBTQ community, and sometimes it felt as if people were drawing on this notion of a minority stress. Participants like Natalie spoke of this confluence of factors as shaping their introduction to and eventual difficulties with substance use. She says, I think around 16 is when I made a few friends from an LGBT group, and we all started hanging out. And that really started my experiences of alcohol and marijuana. People who were already dealing with different struggles in their life, like, the struggles that come with being LGBTQ+, they find that the effects of whatever drug they're taking make it better, so they start taking it all the time. This is a kind of narrative I think we've heard in some contexts in the past. Participants also described their impactful use as impinging on their personal agency. So for participants like Claire, these understandings appeared to draw on stereotypical notions of addiction and a sense that they were becoming unable to regulate their substance use due to a combination of chemical and psychological dependency on a substance. Participants also recognized their substance use as impactful when it conflicted with personally held beliefs and values. Ben told us about how his methamphetamine use enabled him to engage in sexual encounters that he later viewed as shameful. He said, I didn't have sex with my peers on meth in the same way that others did. I think that I got a lot more through cruising, through hookup apps and casual encounters with strangers at saunas, rather than making connections with my peers through my social circles. I think it was very different from me. And he went on to talk about the shame he felt as a consequence of that. Ben highlights how personal values are often shaped by dominant social or cultural expectations, which can carry biases that stigmatize substance use and non-heteronormativity or queer ways of being. In his case, his perception of substance use as harmful is closely tied to his discomfort with the types of sexual encounters he has while using. And while some participants described similar experiences as liberating them from ingrained prejudices about non-traditional sexual intimacy, queer intimacy, Ben instead experiences his methamphetamine-induced loss of inhibition as a source of distress. Impactful use was also described as substance use that led to injury, impairment, other forms of psychiatric harm, things that we'd be familiar with in many populations. And there were also drug effects. The drug effects that diverged from participants' expectations were another way that impactful use was experienced. In many instances, not only were participants often deprived of the beneficial effects that they sought to access through their substance use, but they also experience a range of undesirable effects. And often these changes in substance use effects were due to things like the purity and chemical composition of the substance being used, a person's physical setting or psychological state, drug tolerance, and interactions with other substances. I think taken together, the participants' understandings of impactful or problematic use perform various functions. Simply realizing that one's use is problematic may not translate directly into help seeking or even moderation of a substance use. However, these kinds of personal insights or reflections are absolutely crucial in shaping future decision making and serve as key factors in enhancing the effectiveness of therapeutic interventions, whether that's peer-based or through other methods. Responses to impactful or self-identified problematic use could take various forms. So people could respond by engaging in self-care, by professional support seeking, and by peer-based or community care. I don't have time to talk about each of these three in the ways that people were enacting them. I mean, each of them could have been a presentation in its own right, so I hope you can forgive me. I'm only going to focus on peer and community care in these last 2 minutes. Participants like Rowan talked about how substance use was accounted for and accommodated within social gatherings and other community queer settings, citing a privately hosted party that they were invited to as one such example. They talked about, in the event description, they put a whole accessibility thing about their house. They were like, hey, if you want to do anything funky, go to this room, don't go outside. You know, we have a naloxone available. Don't be a dickhead. Like, this is who's going to look after you. Within this context, though, were also more individualized forms of mutual support and care, including emotional and moral support from LGBTQ+ peers. This was especially important for participants like Morgan, who spoke about being alienated from their biological family and facing ongoing difficulties in managing their impactful use. Morgan told us, I still get suicidal, but I'm better equipped at finding healthy outlets. You know, I've got more support now. I've got people I can call. I've got people I can talk to. I'm not surrounded now by just people who abuse me constantly. Instead, I've got people that are proud of me. And when I left my family, I was surrounded by the bisexual community who welcomed me with open arms. Most clinicians that we interviewed, or AOD service providers we interviewed, noted that LGBTQ+ clients and patients often demonstrated a greater degree of drug literacy and were more forthcoming about their substance use. Most strikingly, there were 2 clinicians who had worked with high volumes of both LGBTIQ populations and heterosexual and cisgender populations. And they talked about the ways that certain practices, particularly things like chemsex or sexualized drug use, that have for a long time been associated only with gay and bisexual men, now appear to be having the greatest impact in terms of who is most likely to be having the biggest problems among heterosexual or cisgender service users. So this, it was Richard who told us, I would say that the LGBT ones who come to us who engage in chemsex, they're more aware of this substance use and its impact. The ones who are straight, probably caught up in the party mode and don't really have a good understanding of what's happening to them. That's a kind of generalization, but I think that the gay community, there's a better literacy around substance use, rights, and consequences. So just to very briefly conclude, I really want to emphasize that, of course, drug use could be pleasurable and celebratory and a really big part of queer identity affirmation. But it could also be impactful, and for some people it became a problem. How and when they came to think of their drug use in that way was shaped by many different forces, unintended consequences, a misalignment between actions and values, and queer community social norms. And I was only able to touch on a few of those in these 12 minutes. But I think there was consensus among participants that attitudes towards substance use within the LGBT community were more nuanced and more progressive than we see in other populations. Rather than simply being permissive, though, participants described a community that often approached approached the topic of substance use in all its nuance and complexity. And this contrasts, I think, with a somewhat popular view that the LGBTQ community celebrates substance use without any heed to the negative impact that the use can have on community members. Participants genuinely agreed that the community was indeed accepting of substance use, but also highlighted the ways in which this acceptance coexisted with open discussions about safety and well-being. I think these findings tell us a lot about the need for interventions that encourage reflection to identify if, how, and when drug use might be becoming a problem for an individual, rather than imposing a diagnosis from the outside. And remarkably, there's a real absence of this kind of very early stage intervention in the LGBTQ harm reduction space. But I do think this kind of reflective early intervention could be really valuable, particularly if it were able to capitalize on the significant capability and capacity of queer communities themselves. Thank you very much.
Thank you, Adam. You certainly gave us a lot of food for thought and a lot of reflection about how we think about drug use and sexuality, and so much to say, but we'll go straight to the questions. I'm sure we have some questions for the panelists. So we will take 3 questions. I'm sorry we don't have too much time, but we will take 3 questions if that's okay. So anyone with a question for our panelists?
I'm loaded with questions, actually, but I'm very interested in your description of your amazing project in Indonesia and how you clarified with the trans people about their own notions of harm. I predate Stonewall and have the experience of the bad old days, but it was very common in San Francisco. Like a phrase was, "Did he beat you, girl? He isn't a real man unless he beat you." And I would imagine that it would be very interesting talking about negotiate, well, is that harm or isn't that harm? Can you say anything more about that?
Can I respond? That's a really interesting question, and it was a very challenging process. These issues came up immediately when we started to explore what harm meant. We realized that in a lot of the early pilots and community consultations and conversations we were having with the trans community, a lot of even within our team, there were notions around violence being part of the feminine experience that some of the trans women were embodying. And there were, in the formative study that I didn't have a chance to explain too much about, we also found a lot of notions, particularly around emotional abuse and financial dependency, partner coercion around the use of
testosterone and hormones to look more feminine, as not necessarily being considered violence, and often being kind of discarded as well. This is the life of a woman. This is the life of a trans woman. This is what it's like, and I'm not sure that we are still struggling with that dynamic and conversation. And one strategy that we used was to really work together with some of the community leaders in the trans community, many of whom have been pioneers in the HIV movement in Indonesia, to kind of work with younger trans women who may not have had that same perception of risk. And there's been a lot of mentoring within the community and education within the community within that space. So really difficult conversations that we're still working through.
Thank you so much for your presentations. They're brilliant. I'm very interested in learning more about kind of the come down aspect of stimulants, because I think a lot of times we give supplies, right? We say this is how you use more safely, but the after effects, I'm interested to hear more if your participants were talking about depression, anxiety, kind of that come down, and if there are any sort of programs that have come down spaces, because many don't, just places for people to kind of chill out and de-stimulate, if that makes sense.
Who are you directing the question to, or
just anyone that like to answer?
Okay. Anyone? Coming down from stimulant use. Yes. Any kind of harm reduction strategies that have been employed to help people come down, any sort of spaces that you know of? Okay, all right, let me give it to you.
I do not have a first-hand experience, but yesterday during the youth caucus, I met someone. They're from the US and they were originally from Puerto Rico, I guess, and they said that they have been working in drop-in centers, especially where people can come and after they get high, so that they can relax, and so maybe you can add more.
Vou falar em português e a Silvia vai traduzir. Pelo Edley, a gente tem as nossas convivências de Chemsex e vem chegado bastante pessoas que pós-uso vem demonstrando alguns efeitos de saúde mental, né, como depressão, ansiedade, às vezes até fobia social por ficar muito tempo reservados num lugar fazendo essa prática.
So in our center in São Paulo that is called Edley, we have some convenings and getting together especially after people has been using drugs.
E aí a gente pensa nesse lugar da convivência de forma singular, né? Então a gente pensou uma convivência onde a gente consegue acolher, conversar e indicar espaços também a partir da articulação com o SUS e com SUAS, também a articulação na rede de pessoas que a gente pode confiar e até indicar para começar um cuidado de saúde mental que não vai fazer o estigma ou preconceito ali na hora do atendimento.
So we have found in these spaces that they do come with, they express that they are feeling some mental health issues like depression or anxiety after some drug use. So it has come to us the importance of being able to to show them a path to deal with those, because sometimes they just are the door to understanding some other mental health issues. So we relate with the public health network, and we also work with our own network of people that we trust, like peers, but also friends, people that are part of the program, so we can relate them with them so they can start understanding what's the effect of that, feeling those mental health issues post the use of any substances.
E aí, assim, fazendo essa prática em conjunto, né, tanto a gente como profissional, quanto a pessoa que está passando por essa situação, a gente consegue pensar em estratégias para minimizar esse sofrimento psíquico, né? Tanto pensando na cultura, por exemplo, quanto os outros espaços que a gente pode estar discutindo sobre os efeitos pós-uso e pós-prática.
So one of the key things for us is not to see it as a singular thing, like someone that needs to be lived as an individual, but as a collective too. And so we want to give and offer some experiences, and we go back to using culture and art and spaces of pleasure also in the post-use. So it's not to go through it alone, you know, and think that, you know, go back to thinking that you did something wrong and now you're feeling bad, but it's like you also need your community, you also need your music, your culture, your spaces to go through also that psychic moment or that you're feeling all those situations, mental health situations.
E aí, para finalizar a resposta, acho interessante, profissionais de saúde mental, pensar em se sujar com a realidade da pessoa, né? Sem querer trazer já um protocolo pronto para conseguir fazer o atendimento, mas tá ali junto, entendendo aquela realidade de forma empenhada e por inteiro. E eu acho que é um pouco disso. Não sei se respondo o que você perguntou.
And also we think that it's very important for doctors, psychiatrists, and physicians that are working with mental health to understand that accompanying a person in that moment cannot be a prepared protocol that comes from a book or that comes from somewhere, but it is just getting to know the person and really diving into that person reality so they can understand why those situations or those moments of post-use depression or anxiety, where are they coming from and what are they are really expressing. And that's something that we could do if we face it like collectively, where there is like doctors, psychiatrists, and physicians involved in the person's life as a collective in the horizontally, and also dealing with this, taking into consideration dance, music, art, and all those ways of pleasure. And I don't know if that responds to your question.
Well, thank you so much. Before we appreciate our panelists and let everybody else go, we want to draw your attention to a session that's happening tomorrow. We were supposed to speak about consent today, but I think we had so much to say we didn't get to that. So there will be a creative session in the creative space on Wednesday at 11:30 around sexualized drug use and consent, which is really something that ties into what we're talking about today, and just such an important conversation. Tomorrow as well at 2:30, there will be a session on reconceptualizing chemsex through the experiences of GBMSM in the Global South. So we invite you to that as well. And thank you so very much to our panelists for all the work. And thank you to all of you for being here with us. Have a very good evening. Buenas noches. And thank you, Emily, for making all this happen.